Hello everyone, today we'll be talking about principles of management in volatile alcohols. The reason I'm doing this is because most of us will forget these volatile alcohol specifics as we don't encounter them frequently enough. So we'll try to understand some basic principle which will last in your memory for much longer time. We will not talk about individual volatile alcohols in this one. Always send serum osmolality when you encounter a patient with coma of unknown cause, suspected overdose or suicidal attempt, or unexplained anion gap metabolic acidosis. Calculate the osmolar gap by using your calculated plasma osmolality and subtracting it from measured plasma osmolality. The first step is to remove the component of ethanol from osmolar gap, as ethanol ingestion is the commonest volatile alcohol to be used. And the way you do it is by dividing the ethanol level, if available, by 4.6. This is your osmolality contribution by ethanol. And if you still have persistent osmolar gap, that means there are additional alcohols besides ethanol. Understand that normal osmolar gap does not rule out volatile alcohol ingestion. Large volatile alcohol molecules contribute lower to osmolar gap. So if your methanol levels are 50 mg per dl, which is a toxic level, will increase your osmolar gap by at least 15, while ethylene glycol will do it only by 8. Diethylene glycol will only increase your osmolar gap by 5. And this is a problem because your normal osmolar gap is less than 10, however the range is minus 10 to plus 10. So if a patient started at 0 and had toxic level of ethylene glycol, his osmolar gap will be still 8, which would appear to be in normal range. This is the only part you have to remember for reports and exam is the key differentiating features between all the 5 different alcohols. So methanol toxicity is suspected with adulterated alcohol, ethylene with antifreeze, propylene glycol with IV drips used in ICU, and isopropanol with rubbing alcohol. The first 4 alcohols have acid intermediates, so cause anion gap acidosis. However, isopropanol does not cause anion gap acidosis. However, in very early in presentation, the anion gap acidosis will be absent as these alcohols are not yet metabolized. Some of the other differentiating features include visual problems with methanol, elevated beta hydroxy, that is the serum ketones with ethanol, calcium oxalate crystals in ethylene glycol, very high lactic acidosis in propylene glycol, and ketonuria in isopropanol. Always consider other cause of altered mental status and do not hang your head even if your patient has history of antifreeze ingestion or high osmolar gap. You can inadvertently miss patients with trauma, intracranial hemorrhage, or other ingestions. Know which alcohols have toxic metabolites. All alcohols are metabolized by alcohol dehydrogenase into acid intermediates, and this happens primarily in liver, and some of it is exchanged unchanged in urine. You have to understand that not all acid intermediates are toxic. Only methanol, ethylene glycol, and diethylene glycol will form toxic intermediates. These intermediates will be subsequently metabolized into non-toxic final products or be excreted out. Folic acid is useful in converting formic acid into carbon dioxide and water, while thymine and pyridoxine are useful in converting glycolic acid and glyoxylic acid to less toxic intermediates. Alcohols cause osmolar gap and they do not cause any anion gap, while your acid intermediates will cause anion gap but will not cause any osmolar gap. So you can use this information to figure out the relative concentration of each. So very early in presentation, you will have high osmolar gap and very low anion gap. However, as the time progresses, these alcohols will be metabolized into their respective acids and your anion gap will decrease while your osmolar gap will decrease. All alcohols are metabolized by alcohol dehydrogenase. If you have a large osmolar gap, that means you have a lot of volatile alcohol still in your system. And if that alcohol forms toxic acid intermediates, you can block alcohol dehydrogenase with fomepizole or ethanol to prevent the formation of these. Methanol and ethylene glycol are the ones which form toxic intermediates. If the alcohol does not form toxic intermediates, you do not really have to block this alcohol dehydrogenase unless high alcohol levels or non-toxic acids are causing severe symptoms. This occurs in patients with propylene glycol and isopropyl alcohol poisoning. If you have large anion gap, that means your volatile alcohols have been metabolized. So you have to figure out if the patient has methanol or ethylene glycol intake. If you do have intake of methanol or ethylene glycol, understand that inhibiting alcohol dehydrogenase will be less useful. However, since you do not know how much ingestion was present, you should go ahead and probably give them these medications. Once you have acid intermediates, there is only two ways to get rid of these toxic acid. First is removal by dialysis, and second by accelerating their metabolism using some vitamins. Intermittent hemodialysis removes alcohol faster than continuous hemodialysis. So you can see in patients with methanol and ethylene glycol, their clearance on CRRT is much smaller than hemodialysis. However, if you do not have hemodialysis available immediately, you can certainly start continuous renal replacement therapy. Ethanol and fomepizole are dialysable, so make sure that you adjust their dose during dialysis, and you can take the help of your nephrologist or pharmacist. Keep the acids in their ionic state. Acidemia pushes this reaction towards the left, forming more formic acid. As you can understand that neutral acid can cross cell membrane, and it's the intracellular collection of these acids that causes toxicity. The ionic form of acids cannot cross the cell membrane. You can use sodium bicarb to keep your pH more than 7.35. This will shift this reaction towards the formation of format ion, and these ions cannot cross the cell membrane and will result in reduced toxicity. The more important thing is when you are planning to intubate such patients, make sure that you prevent respiratory acidosis at all costs. So make sure that you give them enough minute ventilation. If you give them lower minute ventilation, these patients will develop respiratory acidosis, therefore shifting this reaction to the left and causing more toxicity. Most of the volatile alcohol results are send out labs, and they are not often available immediately. So you can use your serum osmolar gap to follow the levels of parent alcohol and anion gap to follow the levels of subsequent acid metabolites. Since volatile alcohols are small molecules, these can be excreted unchanged in the urine. For example, 40% of propylene glycol can be excreted unchanged in urine, while only 5% of methanol is excreted this way. So you can use IV fluid and diuretics to help aid excretion of these alcohols as well. So bringing it all together, methanol and ethylene glycol are the ones with toxic intermediates. So use fomepizole in these two alcohol ingestion. Use sodium bicarb to alkalinize the serum and to keep the acid in their ionic forms to lessen the toxicity. In methanol toxicity, use folic acid, and in ethylene glycol toxicity, use thymine and pyridoxine to help formation of less toxic intermediates. Dialysis is indicated in methanol and ethylene glycol toxicity, so understand their indication. You can also use dialysis in propylene glycol and isopropanol toxicity if there is severe clinical symptoms. In ethylene glycol, you can use IV fluid and diuretics to get rid of the calcium oxalate crystal, and in propylene glycol, discontinue the offending medication. Treatment of ethanol and isopropanol is mostly supportive. Thank you.